webinar I've done. So if I start doing anything odd here in my office, please someone let me know and I'll stop moving my arms around. I have been asked to talk about the diagnostic approach to the patient with a skeletal dysplasia. There we go. Have to give you my disclosures here. I do receive some funding from BioMarin, QED. These have all been reviewed. Topics for today, we're going to hit big topics. Happy to answer any kind of questions at the end, but hopefully this will give a nice big overview of when a small child is a small child that is an abnormal situation, when that small child really sort of fits into a dysplasia category better, and then some overview on diagnostic workup and genetic testing options for these. So we're going to start off with the very basic question, when is small abnormal? And these are the key take-homes out of this section, that we need accurate measurements and appropriate curves. I'm going to talk about discordance and concordance in measurements, the pros and cons of longitudinal over cross-sectional measurements, genetic potential, and we're going to hit on the two biggies there, familial short stature and constitutional growth delay, and then some basic red flags. So ideally, every single patient, every single syndrome would have its own weight curves, height curves, head circumference curves, and that would go for every dysplasia too. But unfortunately, that isn't always possible. And in fact, in the skeletal dysplasias, there are condition-specific curves only for achondroplasia and a handful of other skeletal dysplasias. So often what we need to do are to use standardized curves from the CDC, the World Health Organization, and just plot our patients on these curves and assess the height, weight, and head circumference relative to each other, and then comparing the values if you roll them back over to the 50th percentile for that measurement and then look at the age. So let's go through an example of this. So for a 36-month-old male that we have here, the blue dots represent the length, weight, and head circumference at that 3-year range. And each one of these values, if you look at them, the length is far below the 3rd percentile, the weight is at the 10th percentile, and the head circumference is huge, way off the chart. So considering all of these together, what's actually going on here? Are these concordant? No, not by any stretch. They're quite discordant, but it is a little bit difficult to compare how discordant they are when they appear like this on these curves. So one suggestion is to take those exact same values and roll those back over onto the curve to the 50th percentile and then look at what the age is at that 50th percentile. So for that length of 78 centimeters, it's far below the 3rd percentile, but that's about a 50th percentile for a 15-month-old. The weight is a 50th percentile for a 24-month-old, and then you can really appreciate how large the head is for this particular child in that it's 50th percentile for actually an adult head. So that's extreme discordance across all 3 of those parameters. Now, looking at the patient whose measurements those are here, pictured on the left, the child on the right-hand side, these are completely concordant and normal in achondroplasia, and you can see when you plot those appropriately at the 3-year range for all 3 of those, they're pretty much right at the 50th percentile for those. So when you're not in that situation where you have a patient with achondroplasia and there are condition-specific growth curves, that methodology of plotting on the average curve and rolling back to the 50th percentile sometimes can be very useful to give you a good idea of really what's going on with the growth parameters when you're trying to decide, is small actually pathologic? Do I need to be paying attention to this? And I wanted to bring up quickly here that birth parameters, even in achondroplasia, very often overlap. You can see here at birth in the height curve and in the head circumference curve that there's complete overlap. So it's not always incredibly obvious right at the very beginning. The next couple slides here are just to touch on the absolute value of having longitudinal growth parameters. We really go out of our way in our clinic to try and track down old parameters, plotting them on the same curve with that visit for today, which is what's represented here. These are 2 different 18-month-old females, both at the 25th percentile for height, that's the upper dot, and the 3rd to 10th percentile for weight on the lower dot. But if you take away the big boxes that are covering things here, those same growth parameters at 15 months give you a very, very different conclusion for this individual. The individual over here on the the left-hand side is someone who had some pretty typical growth and then has basically been falling off of the growth curve. And that curve might actually be typical for someone with pseudoachondroplasia, because usually they start falling off the curve at around a year, year and a half to 2 years, and then really level off and fall off there, with weight happening concurrent with it. And that's very different than over here on the right-hand side, where you have someone who is sort of lower on the curve, but they remain there and they're pretty typical. They're on the curve, but at that 3rd to 10th percentile, and so you're less concerned about that individual from a dysplasia standpoint or syndromic standpoint. I wanted to give one slide here just to illustrate genetic potential. We put a lot of stock in what the heights are of the parents, mother and father, when we're seeing a male child here for the data on the left, female child for the data on the right. And basically what you do is you take both of those heights, you give a little bit more, 13 centimeters into that sum. If you're looking at a male child, take away 13 centimeters, add it up, split it in half, and that's basically the range of where that child should be for their adult height. So if you're plotting a child along here as these red dots that are below the 3rd percentile and actually falling a little bit further away over time, that child, based on their parental height, should have a final adult height up between the 50th and 75th percentile. And if this child continues on the trajectory that they're on, they are far below where that is. And I always say to my patients, it's not that I want to push, you know, every single person doesn't have to be 6, 7 feet tall, but if you're not growing to the genetic potential that you were made to grow to, then there's something going on there that we're missing. And so we're due to look into this further to figure out what's going on. 2 other examples of when being small can just be a normal variant. So you would wipe off the possibility of a skeletal dysplasia and you'd be less concerned for a syndromic diagnosis too. One of these examples is familial short stature. So what's common in this situation is that you've got a family history of pretty much everybody in the family being a little bit smaller than average. They're still in the average height range, but just a little bit smaller. They started off at a normal birth size. They were a little bit slower to grow through childhood. Secondary sex characteristics in puberty occurs at the normal time. Adolescence occurs at the normal time. And you can see here on the month curve on the left and then the year curve over here on the right, they remain on the curve just at the lower end of normal, and this is familial short stature. Now that's a very different pattern than what you see in familial slow maturation, or that's also called late bloomers. The pattern here is that many times within the family history, you hear the mother or the father also went through puberty later, and secondary sex characteristics happened a bit later. Again, birth size is very normal. There's a slowing pace in infancy and early childhood of the linear growth, and their adolescence and puberty happens a little bit later, but they end up pretty typical, middle of the road often, for their final adult height. And if you would do a bone age on one of these children, like say at 12 years of age, you're plotting them here, a bone age of an individual with constitutional growth delay or familial slow maturation very often will be delayed. So that's telling you that their bones or skeletons have a bit more time to grow, and that is the pattern that you would see then in this type of a growth pattern. So we've talked about normal variations in growth. These are some good thumbnails for when size is abnormal and it warrants looking a little bit further. And I want to make the point that the majority of these on this list, aside from where I have it crossed out here at the bottom, I'm going to get to those, most of those are perfect red flags for skeletal dysplasias too. So stating the obvious, they're off the curve. The curve was made for a very good reason, because the majority of the population should be on there. And if someone is below it, that could be where they're just supposed to be, but it warrants looking further at what the cause is for that. If someone is having growth failure due to caloric insufficiency, an underlying metabolic condition, a heart defect, something like that, the weight falls off the curve first, then the height, then the head circumference. If you're looking at something more in an endocrinologic basis or even a dysplasia, it's typically the height that falls off first. The weight may not fall off at all, and the head circumference many times stays completely normal. So if you deviate from that sequence of weight, height, then head circumference falling off, that's just another little red flag to look a little further for a different cause for that person's abnormal growth. A person who might cross over 2 percentile lines after 2 years, and I mean the large percentile lines, so 5th, 25th, 50th, 75th, 95th. Unmet genetic potential, which we just talked about, not meeting the potential that you would expect from the parental height. Short and obese, and I bring that up because overweight children are, in general, tall. So if you're finding someone who's particularly short and overweight, many times that is a lean-to into an endocrinologic situation going on there. Discordant growth, as we talked about, where the percentiles for height, weight, and head circumference together do not match up, or disproportionate growth, and I'm going to talk about that specific to dysplasias. That's a big red flag for dysplasias. And then the last two, very often when there's cognitive impairment or congenital anomalies, I suppose I'm preaching to the choir here, but that always should be the red flags for other syndromic or chromosomal abnormalities, other syndromes that might be going on. Less so for skeletal dysplasias, which is why I crossed this out. There are a few dysplasias where you can have cognitive impairment and you can have congenital anomalies, but in general, the skeletal dysplasias are skeletal conditions that primarily affect the skeleton itself. Okay, so moving into the second bullet here. So we figured out, okay, this child's small, there are some issues going on here, we need to look further at it. What makes us lean over into that area where this smaller child is more representative of a skeletal dysplasia? And the key take-homes for this are disproportion, family history, some prenatal clues, and the abnormal skeleton itself through radiographs with some accompanying features. I've got a little asterisk here because I'll show you a couple of sort of classic ones that we'll talk through. So from a disproportionate standpoint, what I'm talking about are the limbs compared to the trunk. So over here on the left, we've got the individual with fairly short limbs compared to the trunk and head here, versus this child over on the other side with spondyloepiphyseal dysplasia, type 2 collagen condition, where the trunk itself is very short. So you can see from where this pectus is, this isn't a whole lot of distance here from the neck to the sternum, and the limbs, and especially the hands, are actually appearing very typically sized, actually. So in average stature individuals with normal growth, I wanted to show this picture here on the left-hand side. This is how we all change over the course of development from the prenatal period up to birth, and then as you get into the school-age years. In that, by the time you're about 6, 7, 8 years old, so that's, now you can look over here on the right-hand side, by the time you're 6, 7, 8 years of age, the ratio of head to pubis, so your upper segment, to your lower segment, pubis to the floor, is basically 1 to 1. And that's what we would expect in typical growth. So if you're seeing a 10-year-old who happens to plot an upper to lower segment here at 10, around 1.2 or 1.3, that might not seem numerically like a very big difference from 1.0, but actually that's very, very dramatic in terms of the disproportion of the upper to the lower segment. Similarly, from arm span to height, this is another big tip-off that you're perhaps in a dysplasia category. There isn't a big range shown on this figure over here on the right because, in fact, the ratio is so close to 1 in everyone once you reach that age that you really can use that as a good indicator that perhaps you've got limb shortening or trunk shortening that's significant. Abnormal limb segments, this matters very much. Which part of the bones may be affected. So in the individual over here on the left, someone with achondroplasia, they have rhizomelia. The root of the limb itself, rhiza meaning root, is shortened. This individual here with mesomelia, Langer mesomelia, for example, this is an individual with mutations in both copies of SHOX. This distance from this area here basically to this area here, I'm hoping you can see my arrows that I'm pointing at here, that's the entire forearm. So meso meaning middle, of the limb is what's affected. And then in acromesomelia, the hand or distal part of the limb is what's affected. So the shortening, dramatic shortening of the hand and the digits, along with some middle segment shortening as well. So again, another big red flag or tip-off that you're in a dysplasia category. Now with everything in genetics, everything in medicine, there's always exceptions. So this is an individual with pseudoachondroplasia, and this is the one that I was speaking about earlier with the growth curve, that very often people with pseudoachondroplasia start off pretty typical in their height, and then by the time they're around 1.5 years to 2.5 years, then they have started to just at that point fall off the curve and also become a bit more disproportionate. So you can see here in this individual, this is the same person here. She appeared pretty proportionate in her limb segments on the left, and then over time, the disproportion evolves. Another exception about the proportionate, disproportionate idea of leaning into a skeletal dysplasia is primordial dwarfism. Primordial dwarfism, the individuals who have this are in fact quite proportionate. This is considered in the dysplasias. Here's a listing here under the image of this little girl with her father of some of the conditions that are in the group of the primordial dwarfism subtypes. But those individuals are quite proportionate. You can see that in comparison to this child in the red outfit here who has achondroplasia, who I think you can appreciate the shortening of different segments of the limbs. Family history, many of us have probably learned this the hard way in clinic, but asking the family history and taking the pedigree is very important, and just flat out asking how tall is everyone, you know, as you're collecting information about the family, because sometimes families don't consider the short stature to be any sort of an issue and don't mention it, and it's a really obvious point that if everybody in the family would have happened to have been at the appointment, might have gotten to that point a little bit quicker. Plotting genetic potential, and also asking questions about parental puberty and how quickly those how those evolved for those individuals. Skeletal dysplasias can be dominant, recessive, or X-linked, but many times the skeletal dysplasia patient is in fact the first person in the family with the condition, so just asking those general questions. And phenotypic severity can often vary within a family for some of the dysplasias. The short stature itself, if a person has a mutation in a gene that's causing a short stature dysplasia, there are few instances where there's decreased penetrance or a situation where someone could truly be average stature but still have a dominant mutation, for example. But the manifestations of some of the dysplasias, even things in the achondroplasia realm, OI realm, can vary significantly within the family. So just taking that time to really explore the phenotype in those individuals can help you in reaching that diagnosis for that individual also. On the prenatal side of things, sometimes we can get great clues that we are actually looking at or thinking about a skeletal dysplasia. These are big generalities here, but a couple of really nice landmarks to keep in mind. The earlier a skeletal problem is detected by ultrasound, in general, the more severe it probably is. So a good example, I guess, of the opposite of this is in achondroplasia. Many times you don't even really appreciate the foreshortening of the limbs or even the macrocephaly until far into the 3rd trimester, which is the point at which most people aren't getting ultrasounds. In contrast, seeing fractures in an infant fetus with OI before they're even being compressed or having that opportunity to fracture for mechanical reasons, but they're already fracturing, is a tip-off that this is going to be a much more severe phenotype of that particular dysplasia. Sometimes it isn't possible just by ultrasound imaging what type of dysplasia it actually is, but there are some good measurements that you can utilize here to hone in a little bit better on whether the dysplasia is actually lethal or non-lethal. So in ultrasound imaging, sometimes we're looking for postnatal dysplasia features that we might be able to appreciate on the prenatal side. For example, some of the short rib polydactylies have very hypoplastic, very small scapula. And we've added to our ultrasound protocols here to actually measure and look at the scapula, because sometimes then we can hone in on that group of conditions. Usually those ultrasounds are done at a standard of care time of around 18, 19, 20, 21 weeks in there. And this image that I added to the picture down here in the bottom from Deb Kraka, I want to show you that you actually can see a lot of the skeleton even by that point, so you can get some great clues. Measurements are usually very helpful, and one of these ratios, the chest circumference compared to the abdominal circumference, if that ratio is less than 0.6, that's suggesting that there's a lethality to that skeletal dysplasia. Femur length in comparison to abdominal circumference, less than 0.16 suggests lethality also. And usually the femur to foot ratio is about 1. So if you see a disproportion there, that allows you to hone in on where there may be some shortening of the long bones. And then this last set of bullets down here, I found this to be very helpful in a couple of different ways, but especially so actually in the newborn period, when I've seen infants that maybe have a cleft palate or they have failed their hearing screen. And in a very basic film of a newborn, if there isn't pubis ossification and they're well into the 3rd trimester or even at term, that could very well likely be a type 2 collagen condition. So that's a very nice landmark to be able to use, and these landmarks match within the prenatal period as well. So just some big generalities here when you're, again, doing ultrasounds, say the fetus is a bit smaller, measuring smaller than you'd expect for the gestation. Another prenatal consideration or clue that you could get is that sometimes genetic syndromes also include that fetus actually being small for gestational age. So in those instances, sometimes the 2nd trimester biochemical testing as a screen may help point you in the direction of a trisomy, for example. Non-invasive prenatal testing now is available where a maternal sample is taken looking at cell-free DNA to look for aneuploidies or abnormalities of the numbers of chromosomes, and some single gene conditions as well. And then invasive testing options, meaning chorionic villus sampling or amniocentesis, of course, could be done, but turnaround time then is a major factor for some of those as well, to extract the DNA and then actually do the testing that you want. The skeleton itself, then moving into the infants now born, and we're now evaluating them in clinic, x-rays are sometimes very, very helpful to really narrow down which parts of the bone are affected and is the spine affected as well. And sometimes there are very classic features or anomalies that really point you towards a very specific dysplasia, but sometimes you're only able to use the spine, yes or no affected, and which part of the long bone is affected to narrow that down. So this image is to show you all the component parts of a full skeletal survey that you may do in order to assess all these parts of the skeleton. I put a highlight here around the flexion extension C-spine. Whenever I'm talking about skeletal dysplasias to any crowd, and if you as a healthcare provider meet someone that you're feeling like, okay, this is an individual any age that is much smaller than I would expect, and actually on my differential is a skeletal dysplasia, I would ask that you consider doing a flexion extension C-spine film, because whether or not you hone in on a single diagnosis right at that moment, many of the dysplasias can have hypoplasia of the odontoid, which could allow for a lot of movement at the C-spine. And that could really cause damage for that individual. Even without having a specific dysplasia diagnosis, it would be really important to hone in on that. So here's just a very simple drawing of the parts of the bones, the epiphysis, the physis where growth happens, the metaphysis, the diaphysis, and then the vertebra in a lateral position here. And basically what we're looking for when we look at these radiographs is what part of the bone is affected. Is the epiphysis failing to have filled in? Is the metaphysis frayed and sort of broad? In platyspondyly, is there cartilaginous tissue here that's not going to show up on the x-ray that just hasn't calcified or ossified appropriately, and thereby meaning that the spine is involved? So the classic example for a dysplasia, achondroplasia, this is a MA metaphyseal dysplasia. The epiphysis actually initially looks fine. Over time, you see some secondary changes with the epiphysis, but you can see here in the radiograph, the metaphyses are, oops, sorry about that, are broad and irregular, and in fact, that's the classic findings for achondroplasia. The other features radiographically are this sacro-sciatic notch is really small. The iliac bones are very, very broad. Dr. McCusick used to coin that like Mickey Mouse ears, and then these ice cream scoop appearances of the proximal femora are classic features as well. And then sometimes as we meet individuals who are short-statured, they may have other features that go along with their short stature, their epiphyseal changes, et cetera, that really help you hone in. So over on the left-hand side here, the type 2 collagen conditions, one of the classic ones is spondyloepiphyseal dysplasia congenita. You often see a cleft palate, you can have retinal detachment, and then this is a perfect example. So iliacs here, ischia here, but pubic bone has not ossified in, and this is 31 weeks gestation for this infant, and pubic bone should be ossified in by 24 to 28 weeks. And similarly, distal femur, that's a broader range there. Occasionally you can see some delay there, but it should have started to come in a few weeks before that radiograph was done. And then these two brothers on this side with their hitchhiker thumbs and cauliflower ears, those are the classic features for diastrophic dysplasia. So again, sometimes you can see those classic features. Big picture-wise, there are over 250 skeletal dysplasias. Sometimes a pathognomonic feature isn't there, so it's important to have some sort of a framework to organize these. I want to draw your attention to the most recent nosology that I've got cited up there on the left-hand side, up at the top. It's been decades of folks getting together to categorize all the genetic skeletal disorders. We're focused right now on the dysplasias in that first category, but I want to make the point that out of the 461 genetic skeletal disorders that are in this most recent nosology, the vast majority, 92%, actually have genes associated with them. So now in this realm, sort of tying into the last section that we're going to talk about, the genetic testing part of things, the option and the ability to make diagnoses is actually very high at this point. Out of those 461, about 250, as I mentioned, are dysplasias. If you look at all 250 or so of those, it's actually, I would estimate 10 to 15 diagnoses actually constitutes the majority of the dysplasias. And I have to say that not based on like a worldwide registry, because we don't have anything like that, but experience with the large patient support groups, the LPA of America and some of the other international groups, when you have all comers that present to those organizations in general, these diagnoses that are here hit the vast majority of the individuals there. So that's why I'm throwing out that estimate. And achondroplasia is, of course, the most common, probably constituting close to 2/3 of those. So in that whole nosology, there are three basic ways that you can organize the dysplasias and actually all the genetic skeletal conditions, but we're focusing on the dysplasias by gene, by affected bone, or by phenotype. So by gene, I just want to give you one example here. FGFR3 is the causative gene in achondroplasia, but also in thanatophoric dysplasia on the more severe end of the spectrum, and then also in the loss of function phenotype of Katzel. A second way that these conditions are sometimes organized in this particular nosology is by the part of the bone that's affected, and we already talked a little bit about the epiphyses being affected in some of these conditions. Well, there is a whole group of multiple epiphyseal dysplasias caused by type 9 collagen matrulin, or most commonly COMP, cartilage oligomeric matrix protein. And the radiographs that you would see from one of these individuals would have primarily the epiphyses involved. And whenever I show images of abnormalities or something, I want to show you the normal next to it. So here's the knees of an individual with the abnormal epiphyses, and it's diffuse. It's all the epiphyses everywhere, no pubic bone ossification, and a probable type 2 collagen condition. And then you can see it in comparison here to the normal on the other side. And then the third big category of the nosologies are by an additional phenotypic feature. This is a cranium looking straight down, looking at the sutures. This is an individual here that has bicoronal craniosynostosis. And so all the craniosynostoses as genetic skeletal disorders are also categorized in this nosology. and again, for an individual with short stature who may also have the proptosis and the facial differences that go along with the craniosynostosis, that's going to get you into the right category of those genetic skeletal conditions. In the dysplasias, osteogenesis imperfecta and achondroplasia are perfect examples to think of in that grouping. Features might not always be present at birth in the dysplasias, and collectively we think the prevalence is somewhere around 1 in 5,000, whole spectrum from lethality up to average, which I mentioned is average stature or close to average stature, but very likely lower than the genetic potential that you would expect for that family. Primary disorder of bone and cartilage into this dysplasia category. Final adult height, less than 4'10" is a typical cutoff, and that represents 2 standard deviations below the mean for a female. Growth hormone in general doesn't work because it's not a growth hormone issue. Again, exceptions, there is some evidence in hypochondroplasia. This changes things, and certainly for the SHOX gene abnormalities, as in Turner syndrome, growth hormone does make an endpoint difference in final adult height. And I just want to throw out here that with the internet and Little People of America and people being able to find each other within the field of genetic skeletal disorders, there are a lot of people finding each other, and so it's changing genetic counseling for these issues because there isn't a great catalog of what happens when a person with achondroplasia and pseudoachondroplasia have a child together, what to expect in the phenotype of that child. So we deal with that a fair amount of time too, and I'm hopeful that over time we're going to continue to report more and more of that so we can give a better idea to folks of what to expect. Very basic do's and don'ts on the dysplasias. I'll focus on the don'ts. We try not to use the term normal height. I'm average height. My patients, many of them are short-statured. We don't say normal because then that would imply abnormal. We do not use the term midget anymore. That's considered derogatory within the community. And then some of the other things are very specific to genetics, just naming the person and not the person by the condition itself. So using the term skeletal dysplasia or Mary is a patient with achondroplasia. And then finally, the last couple of slides about diagnostic workup. So in addition to imaging, physical exam, family history, there is, of course, genetic testing that's available. We're in a very exciting time and place in genetics right now. Prenatal carrier screening has really taken off. However, the important things to know about this related to skeletal dysplasias is that it's primarily for the recessive conditions and some X-linked conditions. Many of the dysplasias, particularly that list of the ones that you're going to hit the most common in 10 to 15 different diagnoses, the majority are dominant conditions, so it's not going to be able to be picked up on carrier screening. It is helpful if there's a family at risk of a recessive condition, Ellis von Creveld, for example, or something like that. And there are a variety of different panels that are out there, and some of them do include a few dysplasias, but that's not going to be your biggest chance to pick up a dysplasia. Non-invasive prenatal testing, or NIPT, which is basically fetal placental DNA in the maternal blood. Right now, most commonly used for trisomies, sex chromosome disorders, and a select group of microdeletions. But single gene conditions can be picked up there, and there are some panels that are out there for pickup of achondroplasia, hypochondroplasia, thanatophoric, OI with type 1 collagen things, and some of the craniosynostoses as well. And I imagine that will just continue to evolve. If everything goes along in a pregnancy and you're at that point of the second trimester ultrasound, there are skeletal dysplasia gene panels that are available. They have a whole variety of different numbers of genes, collection of genes. Turnaround time sometimes is something to be considered because you are getting to the point of viability and it's changing the possibilities for how you might manage that pregnancy. Amniocentesis is the procedure that would be done to collect the DNA at that point. Sometimes there's specific anomalies that might be there that might help direct testing and be able to get that more quickly done. And I give the example of compressibility of a cranium. So actually pressing with the ultrasound probe, that is actually what you do to look for the fragility in a potential OI patient. And you might be able to direct only to that.
Yeah, you had the choice. I did not.
Was that someone asking me a question? I'm sorry. Okay. Well, the last point is whole exome sequencing. There are cost considerations at this point, and some with the turnaround time. Both of those things are just going to continue to go down over future time, and so I anticipate that as skeletal conditions are detected early on, or even as we're seeing patients, in clinic, we're going to continue to use that more and more frequently. And that's one of my great patients right here at Hopkins with the dome in the background. He gave me permission to use that picture, so I wanted to share that with you. And that's it.